G'day, it's Mick Hughes, physiotherapist and exercise physiologist from the Melbourne Sports Medicine Centre, and you're listening to the Physical Performance Show.
And the winner is...
Failure is not an option.
I've had my ups and my downs.
I think it's an absolutely breakthrough experience.
Welcome to the Physical Performance Show, the show designed to inspire the pursuit of your physical best performance. I'm your host, Brad Beer. Listen in as we delve into how the world's top physical performers achieve their success, as well as the highs, the lows, and the journey of getting there. Let's get ready, set, let's go. Welcome back, or welcome to the Physical Performance Show, brought to you by the Gold Coast Marathon and Pogo Physio. I'm Brad Beer, physiotherapist by trade and training, and founder of Pogo Physio. The aim of this show is to both educate and inspire you towards the pursuit of your own physical best performance. We do this through interviews featuring some of the world's top physical performers and also some of the world's preeminent experts in their chosen fields. We'll cover a variety of episodes, including interest editions, expert editions, featured performer editions, and also coaches' corners. And this week, I bring you an expert edition with Mick Hughes. Mick Hughes is a physiotherapist and exercise physiologist based out of Melbourne, consulting at the Melbourne Sports Medicine Centre. Mick has an expertise in all things relating to ACL, that is Anterior Cruciate Ligament injury. Mick's consulted with various elite sporting teams across his career, and he's also the co-author of the Melbourne ACL Rehabilitation Guide 2.0. The guide is extensively used by clinicians worldwide and also people who have undergone a surgical reconstruction of their ACL ligament to help them get back to sport successfully. Why feature an entire episode on the ACL and ACL injuries? Well, in Australia, there has been an annual growth in anterior cruciate ligament ruptures of 8.8% in girls and 7.7% in boys between 5 and 14 years of age, and an overall increase of more than 70% across males and females between 5 to 24 years in the last 15 years. Rupture of the ACL is a serious and debilitating injury because it lacks the ability to heal and a return to normal function, and inevitably increases the subsequent risk of further knee injury and degenerative associated lesions to the knee. About 70% of ACL tears occur through non-contact mechanisms such as pivoting, stepping, and landing from a jumping position. ACL injuries are reported with an annual incidence of 85 per 100,000 people, with adolescent girls being at the highest risk. And today, Mick Hughes takes us through all things ACL rehabilitation, and we also touch on general rehabilitation principles, and we start with an interesting conversation around blood flow restriction training. Here is this expert edition featuring Mick Hughes, physiotherapist and exercise physiologist, on all things ACL, anterior cruciate ligament injury rehabilitation. Mick Hughes, it's an absolute thrill. It's always something I enjoy, being able to speak to fellow physiotherapists, particularly when we do these expert editions. So welcome to the Physical Performance Show.
Thanks, Brad. It's a pleasure to be here, and thanks for having me on your show. I've been an avid listener for many months now, so I've been waiting for the opportunity and the invitation. So thanks for extending it out to me, mate. I'm chuffed to be here.
Well, Mick, you've certainly got a lot of great information and insights to bring, particularly for the listeners of this show who are predominantly athletic in the sense that they're pursuing something that's physically challenging or of importance to them. So let me start with this, Mick. What's one thing that Mick Hughes, physiotherapist, is learning at the moment?
I'm learning two things, actually. One I'll keep clinically relevant to everyone. I'm actually learning a lot at the moment, doing a bit of background research on blood flow restriction training. I've been reading and hearing and seeing a lot about blood flow restriction and how we can help utilise it in the clinical situation to help our patients with kneecap pain and following ACL reconstructions. And it's fairly new, and I don't think a lot of physios here in Australia use it much, certainly underutilised from what I'm seeing. In America, they tend to use it quite a lot. So I'm currently reading a lot about it to see how I can sort of bring it into my clinical practice to improve outcomes in knee patients and ACL reconstructed patients. So that's spending a bit of time reading about that. Secondly, I'm actually learning to be patient with two young kids running around my ankles, a 4-year-old and an 18-month-old. I'm mastering the art of negotiation with a 4-year-old and mastering the art of deciphering the babble of an 18-month-old, mate. So they're the things I'm learning at the moment. For those that don't know, I only work part-time this year. I'm working 3 days a week. I'm at home with the kids twice a week. So it's a really good life challenge of being an active parent and certainly being around two young growing kids. It's nice to do, but certainly comes with its challenges, that's for sure.
Oh, Mick, well, I'm in a similar season of life, and it's certainly challenging but highly rewarding. But Mick, on the blood flow restriction training, can you give a bit of general overview of what the benefits can be, and with supervision or guidance from someone's therapist, how people could potentially use this? So can you just spend a few moments just outlining a little bit of what you're learning on the blood flow restriction training, what it is?
Well, hopefully give it a bit of justice. I'm certainly only, skimming through some current abstracts and sort of only reading and seeing a little bit. But the guts of what we're seeing is what blood flow restriction allows you to do is to train muscles, in particularly in the area that I've gotten interested in particularly the quads. You can train those muscles at a lower resistance to get a hypertrophy effect. So in the example of a person that's got patellofemoral joint pain or kneecap pain, so our runners out there that might get running related knee pain, and they just can't get the strength into their quads as much as what they'd like to. And typically with our heavy resistance training, what blood flow restriction shows promise in, and it's been done in a clinical trial actually out of Brisbane on this kneecap pain population, that you can get same strength, function and quality of life improvements by training with blood flow restriction at a much lower resistance. So we're talking 30% of 1 RM when you use blood flow restriction versus the traditional 70% 1 RM standard of strength and hypertrophy training. So it's showing some promise that, for people that got really painful, irritated kneecaps and certainly painful, irritated knees, there's certainly promise there where you can really, put the blood flow restriction on, put a fairly low but tolerated load, and still get the strength and hypertrophy benefits slowly over time that can then help improve their pain, their function and their quality of life. So it's a pretty interesting area. My only reservations with it, and that's why I need to read more about it, is just regarding safety concerns, basically occluding, major arterial blood flow to some all-important working muscles. So I guess I just need to do a bit more reading about it to make sure I'm comfortable in actually doing it myself and prescribing it to my patients.
And for those listening in a little bit lost as to how it would practically look, Mick, how would you describe it?
So imagine like a pressure cuff that the GP, you basically put a cuff, the same similar kind of setup, I guess, in a way that your GP would put around your arm to measure your blood pressure. In theory, it's a similar kind of thing, although you've got this sort of connective device to see what your pressures are that the cuff's inflating to. Basically, you wrap it around your thigh, make it firm, increase the pressure, and then away you go and do your traditional exercises with that pressure cuff around your thigh, which would reduce the blood flow to your working muscles. So I guess the mechanisms of how it induces the hypertrophy and the strength gains is a little bit misunderstood, and we don't probably know clearly what is it biologically and physiologically that's happening there within the muscle unit. I think there's a bit of debate, but ultimately what they're saying is that you're actually seeing some really nice strength changes within a muscle group at a very low load. and certainly lower than what we typically prescribe to our patients. So basically, wrap it around, do your knee extensions, do your leg presses, do your squats, all those kind of things you'd normally do, but just with the addition of having that cuff around your thigh.
Yeah, absolutely. And used to be the domain of bodybuilders and weightlifters, and now we may see it having a more permanent home in rehabilitation and beyond. So exciting stuff.
It is exciting, yeah. It could be a game changer to a lot of people. I think it'd just be one of those watch and wait. And until there's probably a few more studies done on the ACL populations, I'd be sort of, just have to sort of just be confident that it's going to have a really strong effect there to bring it in.
So, Mick, you use the word ACL, and this is the focus of our expert edition today. We'll talk about what the ACL is and how it gets injured in a moment, but what does what's spawned this interest for you as a physiotherapist? Why this interest in knee injuries, and in particular this injury we know as ACL, an ACL tear or rupture?
Yeah, I guess it goes back to, it's funny when I sort of reflect on how I got into the whole ACL. I sort of got really stuck into it because I was working with a group of elite netballers, and when you look at the injury profile of netball athletes, ACL injuries are one of the, a common injury that we'd see. Now, when I worked with that club, we only had a contracted list of 10 players. And if any one of those 10 players went down with injury, particularly an ACL injury, our list was then put under the pump. We'd have to get junior players come in to fill in those gaps. And it really sort of, really changed the dynamic of the club. So I really took it upon myself to try and know everything about ACL injury prevention and ACL rehabilitation to really limit the negative, to really limit an ACL injury from occurring, but also we had an ACL injured player that was working through rehab as she turned up on our list. And so I also needed to really lift my game in terms of ACL injury management and rehabilitation as well. So that's what sort of thrust me into the whole realm of, really reading a lot about ACL injuries and injury prevention strategies and all that kind of stuff. I was a bit reluctant early on to be sort of sharing a lot of it online and all that kind of stuff, but I think the more that I started to learn and be more comfortable with sharing it, I think I really sort of wanted other people to learn about all this new research coming out, so we could all be better at managing ACL reconstructed patients and reducing the risk of ACL injuries in the future for everyone. So that's where my motivation came from originally, was as I was put into a job where ACL injuries were a real risk. And I certainly didn't want to have any on my books.
Yeah. And Mick, certainly your interest is, in the things like netball and also football and the teams-based environment. Can you explain the groups that are more at risk of this injury and what it is and how it happens?
ACL, like the common age groups, we've got probably two key demographics. We've got both male and female, but it's more so that 14-year-old to the sort of the 25-year-old. Now, for males, it's going to be the 19 to 25-year-old where we see our peak incidence of ACL injuries. For our females, it's going to be the 14 to 19-year-old age group, so a little bit younger. But ultimately, across the board, that 14 to 25-year-old age group is a really high-risk time point in people's lives where you're at a greater risk of ACL injuries. Interestingly, there's actually in females a second peak of incidence of ACL injuries is actually in their 40s. So out of a study out of, I think, the Norwegian or the Scandinavian countries, I had a look at an ACL registry and they found another peak of ACL injuries, and it was females in their 40s. And the theory is that they tend to go back to recreational sports and activities after they've had kids. So it's the 40-year-old female, 40 to 50-year-old female we also have to be wary of as well.
And Mick, I know you're about to answer the rest of that question, but I have to piggyback off that. I recall one of the ACL injuries I've rehabilitated, and it was exactly that. Mother raised her children, got back on the netball court, the first game, the first 10 minutes of play, ACL rupture. And so it's quite incredible. So Mick, sorry, carry on there. So that's the cohort that we might see this in most regularly. How does the ACL ligament in the knee actually get injured?
Yeah. So it's The most common way the ACL will be injured is via a non-contact mechanism, and we see this typically when the person lands from a jump or makes a pivoting change of direction where the foot is planted and the knee collapses inwards. So often when the foot's planted, the foot itself might be externally rotated. As a consequence, the shin and the thigh bone rotate inwards and the hip rotate inwards, and the person falls into what we call a valgus position, where basically it's a knock-kneed position or an inward collapsing moment at the knee, and that's often where the ACL injury occurs. And it's always going to be within that first half a second, it's 50 milliseconds. So when the foot's planted, it's almost that instantaneous time point. It's very quick when the ACL itself tears. So that's what we typically see there.
And if we've got people listening in, they've incurred this injury, or for future reference, what are the things to look out for, Mick, when someone has an acute episode or incident like you just described, in terms of alerting people that they may have upset their ACL, anterior cruciate ligament?
So the common injury, once again, during that mechanism of injury, when the foot's planted, the knee turns inwards, the person may often feel a pop or a crack at the time of the event. Most commonly, they're unable to carry on in their sport, or their activity that they're doing at the time. They'll often go down like a sack of potatoes and go down in a lot of pain and not be able to get up, and they often have to get carried off the field or helped off the court or wherever that may be. What also happens, because the ACL's got a decent blood supply, within a couple of hours after that tear, the knee's going to swell quite rapidly. So if you, they're the really common key features of an ACL injury. Is you have that instability episode where your knee collapses inwards, you feel a pop, you hear a crack, and the knee swells within a couple of hours. It's almost guaranteed an ACL every day of the week. There are a couple of occasions where I've seen players play on for another 40 to 60 minutes of game time after they've torn their ACL, only to find out later after the game, when their knee really swells up, that they've actually torn their ACL. Now, I don't know how they do it, but there's been many cases that I can think of professional players and even players that I've known and worked with in the past that they've actually continued to play after they've torn their ACL.
So just because you can run on and in some instances play on, doesn't mean that you are exempt of a ruptured ACL.
Exactly, yeah.
Mick, before we talk about some of the mechanics around rehabilitating knee injuries and preventing them, how will the ACL rupture or ACL injury be diagnosed? What are the best tips for us to know?
Yeah, so the clinical exam's pretty important. So there's going to be a really swollen knee, or what we call in the physio world, medical world, a hemarthrosis, and that's basically blood within the knee joint. It's really acutely hot, swollen knee. It's often a little bit bent at the time. The acutely injured knee is really hard clinically to examine. You almost need to examine it right then and there. Because if you let it swell for a few hours and overnight, that swelling only increases over the next 2 or 3 days as the body tries to heal itself. So an ACL injured knee within 3 days can be really hard to actually diagnose. You often need to send the person for an MRI. The easier ones are, a 1 or 2 week later presentation where they've torn their knee, they've just put it down as a sprain, the swelling subsided, things are getting better, but the person that's injured their knee doesn't feel right, so they often come in saying, my knee doesn't feel right, feels a bit unstable. When you test them via the most commonly used, I guess, clinical exam that I would use anyway, it's called a Lockman test. Basically, I'll pull on the shin forward, and if there's more movement on one shin versus the other, and I can't feel an end feel, which is often the ACL, that's often a good clinical diagnosis there. So I guess in summary, if you've got that suspicion that you've had the pop, you've had the crack, the knee swollen, and it's really stiff and sore the next day, I think your best point of call is go see your GP or your physio and get an MRI of the knee to get that accurate diagnosis. Otherwise, a clinical exam in those first few days is very difficult.
And I suspect you've had similar experiences clinically in your work as a physiotherapist, as have I, where people can present years later, sometimes decades later, Mick, and to their surprise, sometimes incidentally, when they're presenting with another cluster of present symptoms regarding their knee, they find out that they've had an ACL deficient or a tear of their ACL sometime in their past. Have you would have come across instances like that, I'm sure?
Yeah, I can. Yeah, one memorable one actually from probably 5 or 6 years ago, well before I was even, really clinically, strongly clinically interested in the ACL. I just remember a case where it was she was in her mid-20s, but, she injured her knee playing netball when she was 15, 16. And so this goes back to, 2011, 2012 when she first presented, but she would have tore her ACL in the mid-2000s. But then, over a series of years, her knee just didn't feel right. She got sore. And she presented really late. But she can recall that time of the injury when she suspected the ACL tore, but it was like a 5 or 6 window later on down the track that it took for her to be, properly diagnosed and assessed and worked up and then probably managed after that. So, yeah, there's the occasional case where you see an older person or a person present very late where they've had a chronically injured knee that's deficient of an ACL. And those people are quite tricky to treat because they often have that kneecap symptoms, knee joint symptoms, a lot of deconditioning. They often put on weight, which often then makes it very difficult to kind of manage. So whether or not they actually need to go ahead then have surgery to stabilise the knee is a really hotly debated topic we've got going on at the moment. But you'd certainly... they're a bit tricky, especially when there's been a few years that have gone past. There's a lot of deconditioning going on through the body.
And Mick, you brought up that interesting point there, being that at the moment there's a bit of a hot debate around people that have ruptured their ACL, anterior cruciate ligament, proceeding to surgery or not proceeding to surgery. In your opinion, professionally, how do people interpret that duality? And obviously, we're going to talk today about the Melbourne ACL Rehabilitation Guide 2.0, which is obviously a post-surgical rehabilitation guide. But what would you say to the person that's found out they've had an ACL injury, they've ruptured it, they've been informed that they would benefit from surgery, but they're also hearing that sometimes it's not the best course of action? How do people make a decision, and what's your advice?
Yeah, it's really tricky. I find that the older person who's less... the older person's more likely to give, so the sort of 30, 40-year-old who's not playing really competitive sports so much, and certainly 40 beyond. I've got a couple of cases at the moment where I've got 50 to 60-year-old patients who tore their ACL skiing, and they're really keen to avoid surgery at all costs and go back to skiing with bracing and adequate strengthening. They're easy because they know and they're comfortable, not going down that surgical pathway because the demands of the knee are much lower than someone who plays, basketball, netball, that kind of stuff. It's the younger person. It's a bit harder to try and get them to think about a non-operative pathway. And also, the thing with an ACL injury is a lot of people do have a successful outcome without surgery and can return back to pivoting sports, change direction sports, but we don't know confidently who those people are. And we're talking in the realm of 50% of people can cope without their ACL in as many as 5 years after their injury, and even up to 10 years down the track. We've got these copers who can cope without their ACL and go back to pivoting and change direction sports without any further intervention. But we don't know who those 50% are. And it's whether or not people want to be in this grey area, what I call the grey area, because you could have a great result without surgery and go the rest of your life without surgery. You could also have a good rehab, go back to sport in your first 1 or 2 games and your knee become unstable again, only to then have to eventually go and have reconstructive surgery at a later date. And that's really tough for people to get their head around, is that they could be 50% will be fine, 50% might have to go have surgery. What reconstruction does, it almost firms up your time frames really clearly and becomes black and white. From the moment you have surgery, you've then got a pretty typical 9 to 12 month rehab stint that's really consistent, and we sort of then think after 12 months you should be able to go back to sport. It's just the people that don't go down the surgical path, things become a bit wishy-washy, a bit grey. You might do okay, you might not, blah, 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 blah. I think that's where we currently stand at the moment. And it's up to the person. Some personality types won't like that grey. Some people just want to have that black and white. some people are happy with a bit of grey and a bit of wishy-washy. And it's just that you got to pick and choose those personality types, I guess, when it comes down to your consult.
Yeah, so obviously it's not a one-size-fits-all answer, and that's to be appreciated. Yeah. I recall at a physiotherapy professional development event that I attended earlier in the year, and the presenter, who was quite profiled in the space, his summary was, if I ruptured my ACL, I would want surgery, and that's what I generally advise my patients. And even with all the mounting, other evidence around sometimes not changing the outcomes if you don't have surgery.
Yeah. And there are many, Kate, and I guess that's the thing. There's now a really good growing body of evidence to say that people actually do functionally well and their quality of life is really good, and they actually can return back to high level sports. That body of evidence is really, really growing, and I think we'll only see more studies in the future support that non-operative pathway. But I think ultimately every person should be given every opportunity to try and go conservative as much as possible. And look, even if that conservative time, that person still feels unstable, they still feel they've got symptoms, what they've been able to do in doing strengthening and conditioning and get that knee quiet, get that knee nice and strong as if they were to go forever without surgery, what that essentially then becomes is really good, strong pre-op physio. Which we know is really beneficial for many years down the track after you have an operation. So there's nothing to lose by waiting and trying to go down a non-operative pathway. It's just hard in the elite world where someone's getting paid to play a sport, even if it's a semi-elite level. Like down here in Victoria, we got guys that get paid $500, $1,000 to play in amateur, like it's almost third tier AFL footy down here. So you got AFL, VFL, and there's people running around in that third tier competition getting paid $500, $1,000 a game. They're the ones that are probably, like they would still be considered, semi-elite because they're getting paid. Their club and their coach want to have really rigid time frames. The guys that literally get paid nothing, they're the ones that should be really encouraged to go for as long as possible, I guess, is because there's no harm in having that really extended pre-op phase.
Mick, before we do the phases of post-surgical care that yourself and your colleague Randall Cooper have outlined so well in the Melbourne ACL Rehab Guide 2.0, the psychology of injury, I think it's worth just hanging on this before we head into the practicalities. Well, firstly, why does it matter? Why does the psychology of injury, or a physiotherapist, and you're speaking to people who are listening in with a knee injury in general, not just an ACL injury, why does it matter, their mental state? It's
a very important topic, and it's a really good question. I think a lot of people do become fearful after their ACL injury because often they need to learn how to trust their knee again. Effectively, when their ACL is injured, it's often done in a landing maneuver or a changing direction activity, and it's an action that they've performed many, many times over, that the 1,000th time their landing's fine. The 1,001st time that they've landed, their knee goes. So all these questions are raised, like, why did my ACL go right then and there? And then they, basically lose trust in their knee again, to be able to get the confidence to run, to jump, to pivot, to change direction. It takes a lot of time to trust that knee again. The other thing with an ACL injury is psychologically, it is a long road ahead. Our typical return to sport, return to training timeframes, or at least, return to training, you can get back to training between 6 to 9 months. Return to sport, we're advocating, beyond 9 months and 12 months. To sit on the sideline for 6 months and not have that weekly, touch base with your teammates and, to go run around with your mates, or to, even if you're not involved in sport, to be not able to run for 3 months or 4 months because of, and if you're a runner, to be able to take that physical activity away from you, it really does play on your mental state and your psychological state. So it's just not the confidence, but it's also too the mental health side of things too, by not being able to exercise as much as what you'd like to. So those two key things is really important to address through your rehabilitation, both in the pre-op stage but also to the post-operative stage. Because one, we want to build confidence and expose that knee need to those demands again and those loads again. But we also too need to manage the physical activity side of things to help the person deal with any kind of mental, health stress, that people use exercise as an outlet for. So we've got to make sure that we're sort of, tapping in and making sure people are, psychologically okay from that point of view as well.
And how, as a tip for any practitioners listening in, what would be your top tip for tapping in to check on people's mental well-being as they go through, whether it's an ACL or a long-standing knee injury or any injury for that matter?
Yeah, it's hard. I mean, just the good old-fashioned, how are you going? How are you? That often is a nice little, evoke of emotion. Like, how are you doing? Are you okay? Those kind of, questions will really sort of get someone to open up and talk. There's some subjective questionnaires we can sort of give to our patients as well. There's 3 that I could think of off the top of my head. We got the IKDC is a nice questionnaire to sort of give us a snapshot of what the person's feeling in their knee. Same with the KOOS, the KOOS. It's a knee outcome measure, and then there's also the ACL RSI subjective questionnaire as well. Those 3 subjective questionnaires could be, pretty useful to sort of give to a patient, because sometimes they're not as open as what we'd like. And if you go through the checklist of questions, you could say, oh, okay, you're not feeling confident in your knee. Let's talk about that. So that's the beauty of some of those questionnaires, because you can go through at a later date and then sort of flag it with them for next time you catch up, and then you can, discuss that point a little bit later. So, yeah, I think the good old-fashioned, how you going? Is everything okay? That's always a good place to start, but those subjective questionnaires are always, will tell a lot about a person if they're not so open and up for a chat.
And I think it's so key before we jump into this recovery process, but I often say pain doesn't really bring people into the doors of a physiotherapy practice. It is that mental unrest, the frustrations, the fears, the anxieties, as you termed it, the lack of trust in their own knee, for example. And so I'd say even, for people listening in, if they are experiencing an injury of any kind, have open dialogue where you can with your practitioner. And it's important, if you don't feel like you're connecting with them, find a way to connect or find a different therapist. I mean, Mick, I always know that I'm going to be effective in a rehabilitation process, particularly if there's tears in the room. Tears are really a good expression of that internal status, right?
Yeah, absolutely. Yeah, it's never a nice thing to sort of watch someone, cry, but at least they're sort of certainly at almost at wit's end and begging for some help and asking for some help. So always have that tissue box ready.
You're listening to Mick Hughes, physiotherapist and exercise physiologist, on this expert edition focused on ACL injury rehabilitation. Support for today's show comes from the Gold Coast Marathon. Just like the Physical Performance Show, the Gold Coast Marathon encourages runners of all ages and abilities to push their boundaries and to strive to complete a personal challenge. The Gold Coast Marathon is held annually on the first weekend in July. It is a must-do event for any budding athlete, weekend warrior, or family looking for a challenge to complete together. Run for the good times at the Gold Coast Marathon. Visit goldcoastmarathon.com.au. Support for today's show also comes from Pogo Physio. We exist to help you get back to your physical best following injury. We want everyone who walks through the doors of Pogo Physio to complete rehabilitation, get back to their physical best, and in doing so cross their physio finish line. We do this through traditional session-to-session, pay-as-you-go appointments, and also some unique and very popular fixed-fee services, including our monthly Wellness Booster packs, starting from a low $195 per month health fund rebatable, including hands-on physiotherapy, active rehabilitation, including exercise physiology and clinical Pilates, combined with use of state-of-the-art equipment such as the Alter-G anti-gravity treadmill. To find out more about Pogo Physio's services or to schedule your 1-hour comprehensive initial appointment, jump over to pogophysio.com.au. For now, let's jump back with Melbourne-based physiotherapist Mick Hughes sharing around all things ACL injury rehabilitation. Mick, let's move from the tissue box to the Melbourne ACL Rehab Guide 2.0. And Mick, it's written by yourself and Randall Cooper, fellow physiotherapist, sports physio. And, it's important that, I guess, we note that it's not an exercise prescription guide. That's individualised and at the physiotherapist's discretion in combination with the patient that they're working with to recover from surgery with ACLs. So can you tell us briefly what it is and why it's useful?
I think probably one of the better ways to describe it is what it isn't. What it isn't is a very rigid time-based protocol, which we typically see. And what it is certainly is more of a fluid, criteria-driven guide to managing an ACL reconstructed knee. Now, Randall originally, my colleague and good mate, he originally came up with this rehabilitation guide to help manage his cohort of ACL reconstructed patients, and he had the original guide out for a number of years online, and then we connected a couple of years ago and basically brought his original guide into 2018, because there's been some brilliant papers published in the last probably 3 or 4 years that really required the guide to be updated. Yeah, basically we don't tell people what to do in terms of exercise selection. I think every ACL reconstructed knee needs an individualised program. We certainly give a couple of examples of what you could do in each stage, but ultimately the athlete, the patient in front of you, needs to have their exercise prescription guided to suit them, not just a very rigid protocol of you must do this exercise, you must do that exercise. So there's certainly a bit of flexibility there, but what we provided at the end of each stage is certainly a list of criteria that you should meet before moving on to the next phase. And I think that's a big thing that we need to do, because going through rehab traditionally was just a time-based thing. And I remember when I was a new grad, they had this magic figure of going back to sport at 12 months, regardless of how your knee looked and how that knee functioned. And I wouldn't be surprised if some of these second injuries that we see in the clinic have got a bit to do with this old, outdated method of just allowing 12 months to pass, and then you get the clearance from your surgeon by a little clinical exam. And away you go. Whereas now we know best practice is pointing us towards that you need to wait at least 9 months. That's one paper showing that, but also to pass a series of discharge criteria. And those discharge criteria are certainly tied into the ACL Rehab Guide, on top of another couple of questionnaires that tell us that you're psychologically ready to go back to sport as well.
So we're looking at a long recovery. There is no shortcuts here. There is no magic pill. If you've had surgery for your ACL, you're going to be needing to prepare time-wise. It'll take time and focus and discipline. So with those things being known, Mick, let's just touch on each of these key phases. And there's really 6 phases, but 5 if we look numerically, with the first phase being the pre-op phase, so injury recovery and readiness for surgery. So what are the most important goals for this phase, Mick?
There's probably a couple of, certainly a two-pronged approach for this pre-op phase. Certainly what the research will show is that if the knee, especially the quad muscles, are of a high standard, and we're talking above 80% limb symmetry between your uninjured side to your injured side. If you've got really good quad symmetry, and we're recommending above 90%. We always set the bar high, Randall and I. We want 90% or more in terms of quad symmetry. What that shows is that you'll have a better post-operative period, and certainly higher strength leads to better post-op outcomes. The second thing with the pre-op phase is that what we can gather in that pre-operative phase, especially if the person isn't known to the clinic or you don't have any, they're not necessarily tied up in an elite program where they do regular pre-season testing and they don't have speed testing or hop testing or jump testing. When the knee's happy and settled, what you can do, you can ask the person to hop as far as you can on their uninjured side. And if they feel strong enough to do so, you could do it on their injured side if they feel strong and stable. And what you can do is you can gather some really valuable pre-op information to be used then and compared against at a later date for return to sport decision making. And we've seen that approach is actually a bit more sensitive to detect those that are more at risk of a second ACL injury than our traditional limb symmetry index, where we get people to hop as far as you can on the left, as far as you can on the right, and compare between sides, because we know slowly over time too, after an operation, you get fitter. You get unfit, or the result of the surgery, you get deconditioned, you get weaker. And you lose that leg power. So if you're comparing your legs against your 9-month self, sometimes that isn't the best judge and it's not the best yardstick. What you should be comparing yourself to is against your fitter former self that you were prior to the operation. So that's where the pre-op phase can be very beneficial, because you get some nice benchmarks to compare against at a later date.
And Mick, just to clarify, quads symmetry, is that size and strength that you're looking at?
Not necessarily size, but sometimes, and it's not always, size doesn't always mean greater strength either. What we're looking at is more so the strength quad symmetry, and that's the strength output. Now, that can be measured via isokinetic testing, which is pretty much the gold standard at the moment. We all don't have the luxury of having an isokinetic machine in our clinics, so sometimes that's impractical. Some of us may have handheld dynamometry, which can be very valuable, and that's what I use in the clinic. I've got a little handheld unit, and I can measure left side versus right side and get an appreciation of how strong one leg is compared to the other. Your other option is you could do a 6-rep or a 10-rep knee extension on a knee extension machine, which can sort of tell you how good one quad is versus the other side too. That could be another objective measure you use if you don't have any of the isokinetic testing or the handheld dynamometry. And if you're lucky to have a knee extension machine in your gym, like most clinics, typically have some kind of weight exercise.
Brilliant. So Mick, that phase is ticked. So someone proceeds to surgery and then is on the other side of surgery, which is technically referred to as phase 1, recovery from surgery. What's important here? What are the important goals, and how long might this take?
Yeah, so clinically, the phase 1 is the post-op phase. Is really the key goals is to get the knee straight, to get the swelling down as much as possible, and just to get the quads to become more active again. I know it's a very vague term, but we would basically just want those quads to recruit when asked. So, if you're sitting someone on the bed, you ask them to tense up their thigh muscles, they should be able to tense them up, with decent capacity, and you should see a bit of a definition there of their quads. They're the 3 key goals that you want to get in that first few weeks. Now, I see that sort of vary a bit. Some people might tick that off in the first week. Post-operatively, some people may still struggle to get the knee straight, get the swelling down, and get those quads turned on till about week 4. Typically, but look, I've seen other people struggle into week 6 and still struggle with these basic ones, and that's why the guide really does take into account individual variances. Some people don't recover from surgery very well. They might have had more pain. They might have had a longer than usual surgery. They might have had a lot more damage to the knee at the time of the event. They might have had other surgeries going at the time. A lot of things sort of can compound that first 1 or 2 weeks. So I think the key measures are, though, just tick those 3 boxes, then we can move into phase 2.
Yeah, and I think it's just a good reminder that these aren't delineated by time post-surgery. They're delineated by ticking off the criteria. So what might take someone a couple of weeks might take someone longer.
Yes, exactly. Yeah, every person runs their race, absolutely.
Yeah. Mick, and just on the swelling, any practical tips if someone's experiencing marked swelling post-surgery, or even in the instance of not an ACL but lots of swelling in their knee? Any top tips from Mick Hughes around managing swelling in the knee?
Yeah, look, I'm sort of certainly a bit more active in my approach. I don't have any magic bag of tricks. Good old-fashioned elevate and ice and compression and ankle pumps. That's probably my standard. There's a few bits of there's those leg compression pumps that you can see out there that you basically put your whole leg into and you zip up and then they pump, that kind of stuff. If you've got the units or if your physio's got them, they can be quite valuable as an assistant. But I think the thing is, you want to do something consistently through each and every day. You want to be attending to that swelling at least three to 5 times a day, and that's where certainly the active quad contractions effectively create a pumping effect to try and remove some of that swelling. So certainly making those quads nice and strong. But the good old-fashioned drainage of elevation, ankle pumps, ice, and a bit of compression garments, they're my go-tos. I'm certainly not I don't have any other special bags of tricks.
Yeah, but the basics work.
Yeah, 100%. Absolutely.
And on the basics, Mick, before we jump over to phase 2, but in terms of a couple of, from your experience, real go-to exercises in this phase, what are a couple of your favourite go-tos?
Yeah, in the early stage, I love a good resisted static quad, and you can do that in long laying on your back. If you can't quite switch your leg, some people really struggle to turn their quad on and push their knee into the back of the bed without any resistance there. And what I find is gives them a bit of feedback. If you roll up a towel, put that underneath their knee, and they try to push down into that towel to squash the knee down, it's a really good active quad contraction. All right, and if we can do those, that's a really nice one. That can progress quite easily into a standing position where you do a similar thing. You stand up against the wall, put something soft behind your knee, and you try and push that knee backwards into the wall with that little bit of resistance. They're my sort of go-tos in those first few weeks. Also, like a good old-fashioned straight leg raise. Like if you can turn those quads on and then you can do a leg lift, that tells me your quads are in really good nick and they'll put you in a good place for that next phase where it's a bit more gym orientated.
And prescription wise, you might be giving a few sets of how many reps?
Look, probably about 2 to 3 sets of 20. I'm a bit of a 100 plus reps a day man kind of thing, 100 to 200 reps a day just to get that constant stimulus. Divide those 200 reps up as you like. You could do 50 in the morning, 50 at lunch, 50 in the afternoon, 50 before bed, doesn't matter. But we sort of want to get that regular attention in that first 1 or 2 weeks. If you can work hard and just, manage your symptoms quite well with some adequate pain relief, work on the swelling, get those quads nice and strong, it really sets you up. So it's the only time in your rehab where you have to probably work so hard is in that first phase where you've got regular, constant attention into the knee. Once you get out of that phase 1, your rehab really slows down a bit. You probably don't have to dump a whole lot of stuff into your day. It's almost like an every second day thing, which I think a lot of people often forget. You got to rest and recovery is just as important as you move through the phases as opposed to flogging yourself in that first, all important 1 or 2 weeks. Now that's completely appropriate. Work hard. But you've got a lot of pain management going on in the background there too. But as you work through the phases, rest and recovery and really proper programming is key to sort of get the job done with ACL rehab.
And I think you noted there that people can forget that they need to factor in rest as they move out of that initial post-surgical phase. But I think it's also, there's occasions where practitioners can sometimes, well-intentioned practitioners can forget to let the patient or the client know that, hey, this is no longer a daily affair. We're shifting now. We need to factor in rest. So certainly can go both ways. Mick, so we're then moving into what you've termed phase 2, strength and neuromuscular control. And so, obviously here you're looking at a few things: strength, balance, coordination, etc. What are some of your go-to exercises and tips for this phase, Mick?
Like I've got an exercise science background, so I think that's probably a big caveat there. Is that I grew up personal training through my late teens and early 20s. So I love the gym. So that's probably a bit more biased to that sort of traditional gym exercise program at this time point. So my sort of go-to in this time point is certainly body weighted squats. Now that can be just a good old-fashioned wall squat or a sit to stand or a Swiss ball squat. Certainly where weight bearing is really important because you get that neuromuscular added. If you're in standing, it helps your proprioceptive ability and all that. So certainly squats are one of my go-to, and as the person feels more comfortable, then we sort of move through loaded squats, the dumbbells, kettlebells, barbells, that kind of stuff as rehab goes on. A good old-fashioned leg press is really important through this time point, so you can get that operated limb separated from your unoperated limb. So certainly we know that when these first 3 to 5 months after an ACL reconstruction, subconsciously the ACL reconstructed patient will offload from their affected knee either to the other side or up to their higher performing bum muscles, so their glutes. So if you don't put adequate load through that affected side, and if you share it too much between two limbs via double leg exercise, you can sometimes underload and undercook your rehab. So single leg training is a must, and that's where leg press is very valuable, because you can modify the load on a leg press machine to suit your tolerance. So that's a good old-fashioned exercise that I like to do. Depending on the graft, I'll bring in hamstring curls at some point. A hamstring graft, ACL reconstructed patient won't love hamstring curls or any active shortening, lengthening, contraction work probably for a good 4 to 6 weeks after the operation, maybe even longer. So we just have to be watchful and wary of that. There's some other things that you could do, like bridging, some chair bridging, some light stiff-legged deadlifts can be a really valuable exercise in that time point until the hamstring feels a bit more stronger, to then work in that traditional hamstring curl exercise and then Swiss ball hamstring curls. Calf raises are one of the biggest ones I see people overlook, and the importance to the calf. I've seen so many people come in 3 or 4 weeks after the operation, and their affected side, their calf muscle has started to atrophy and get skinny as well. And it's because they've been completely underloading that leg, and the calf has now become affected as well. So calf work's really, really important, particularly those that are going back to running-based sports, because you need a really strong functioning calf unit to propel and push yourself along. So if you can lay a good strength base there through the calf in that first 2 to 3 months, that'll also pay dividends down the track as well.
And I mean, these are principles that extend beyond the ACL knee to also the sore knee, the injured knee in general. And practically, I mean, obviously in the guide, there's a very comprehensive and well laid out criteria to follow to tick off to, for a practitioner or a patient if they were leading this approach with their physio or therapist. But Mick, what are some of the benchmarks around quad strength, calf strength, hamstring capacity that you might generally look for?
We've got a battery of strength tests there. So we first want to see 5 good quality single leg squats, and the criteria is there in the guide. We want to see that. We also want to see at least 10 single leg rises off a bench, off a night. So basically it's all going to be relative to the person's height. So you find a height where the person is sitting in a 90-degree hip and knee bend, and we ask that person then to sit and stand at least 10 times. That would give us a really nice indication of their whole entire limb strength. We're also after 15 single leg bridges. Shows us what their hamstring quality's like. We're also after at least 15 single leg heel rises, so their calf capacity, we want to see what that's like. We also want to see what their core strength is like. So we asked them to do a side plank for 30 seconds. And we also want to see their single leg balance as well of a reasonable standard. So eyes open for about 40 seconds, eyes closed for about 10, 15 seconds there. So if you tick all those boxes, we're really happy of your leg capacity to be able to then cope with the demands of running. And that's the key thing, because I think this is why we've got that little phase of the program, is that there's often the decision to return to running can be quite tricky, and it's often time-based decision-making, whereas once again, there's certainly some really basic strength measures and strength tests that should be used to decide whether or not someone can cope with the demands of running. And that's why we've got that phase in there.
And that's a perfect leading there, Mick, to the next phase, which is running agility and land-ins, where the strength-based training, the control-based training can certainly continue and needs to continue. But, the patient or the client or the person starts to incorporate some of these very anxiety-provoking activities, such as running again and jumping around. So what are the key goals here, and any go-to exercises that you would typically include in a program? Obviously, it's always individualised.
Yeah, for sure. So in phase 3, that really attention to train someone to first be able to jog and run straight lines, but then also to factor in some agility and some jumping program, because that's then going to set them up for that sort of return to unrestricted training in sport. So I start off in this phase, in phase 3, just by introducing skipping. Whether or not the person's a skipper or not, some people are just completely uncoordinated and will often constantly be untangling the rope from around their feet. So I ditch the skipping rope, just tell them to bounce up and down on the spot, for 30 seconds and make it as fun as they like. They can bounce forward, bounce backwards, bounce around in circles, do whatever they want to do. But we want to see some continual bouncing up and down, and the knee tolerating it is probably the biggest one. That'll be one of my first introductions. In that same breath, I'd also be getting them to start thinking about some landing drills. So either dropping down onto 2 feet from a 10 centimetre box or a 20 centimetre box, basically stepping forward onto their operated leg and getting them to shock absorb and land. Same thing, moving sideways as well, doing a little side lunge, getting them to hop sideways and get them to stick the landing. That would be my first introductory skills. And then we sort of move that into box jumps, where they're basically jumping from the ground up onto a high box, progressing through to hurdles under 2 feet and 1 feet, both forwards and sideways, and then moving in, weaving in through some high-speed runs and some change of direction drills and all that kind of stuff. So it should be a very carefully planned program, especially that jumping, landing and agility work. And I think that's where a really key feature is of that time. If you don't, as a physio, if you don't have the time, space, certainly the knowledge base to program that running, jumping and landing, it's really critical that you work with a strength and conditioning coach or an exercise physiologist who has the time, who's got the facilities, who's got the gear to help work with your patient to get the best outcome for them. I feel that sort of jumping, landing phase is often completely missed, and then people just sort of, cruise through rehab only to go back to training at a later date, missing that really critical component there. And that needs to be programmed really, really well.
Yeah, so it can't be overlooked. And I mean, I spent a lot of time working with the rehabilitation of runners, and I would say it's probably one common thread that often doesn't happen in return to running programs for running injuries is that, emphasis on the ability to jump, because that's essentially what running is, right? It's jumping from one leg to the next.
Yes, absolutely.
Mick, so moving on to the next phase, and that's this very big area of return to sport, or as I've heard your colleague and co-contributor or co-producer, if you like, of the Melbourne ACL Rehab Guide, Randall, term return to high risk. So how does anyone know when they're ready to return to their recreational sporting pursuit or obviously their professional sporting pursuit following ACL surgery and rehab? What
we know from the literature at the moment is that there are some really key discharge criteria that we should be asking people to meet before being let go back to unrestricted training or high-risk activities or whatever they like to do. And the reason being is that from the research that we saw out there out of 2016 is that if the people didn't pass that discharge criteria, their risk of an ACL injury to either their operated leg or their other leg was 4 times greater if you didn't pass all that criteria. Those that passed all the criteria, they still had an injury risk, but it was far, far less than those that didn't pass all that criteria. So the commonly used criteria that we see right now is strength of the quads and hamstrings. We want to be within 10% of your unoperated limb. And you also want to pass a battery of hop tests. Single leg hop, triple crossover, and a 6 metre time test. They're the key sort of numbers that we're seeing at the moment. For good measure, Randall and I have thrown in a couple of extra tests that we'd like people to also tick off just for a bit of added, I guess, strength for us. We've also lifted the bar a little bit. We want people to be 95% limb symmetry, not just be happy with that 90% limb symmetry, especially those that are going back to, say, something like netball or basketball, AFL, where there's a bit more hard cutting, pivoting and landing along the way. We've also addressed the psychological component too, and we want people to meet certain criteria on some commonly used questionnaires used to determine whether or not someone's ready to return back to sport or not too as well. So you pass all those things, so there's probably about a good 8 or 9, maybe 10 things to address there. You pass all those strength tests, hop test, and also to those psychological questionnaires. We know that everyone's going to sleep well at night knowing that you're going back to sport in your best possible physical shape, but also mental state as well of successfully returning back to sport with a much lower risk of a second ACL injury happening to either side.
If you missed last week's episode featuring UK-based strength and conditioning coach to Olympic and Paralympic athletes and postgraduate researcher Rich Blagrove, it was an expert edition focused on all things strength and conditioning for the endurance runner. Here's a little snippet of what you missed.
So with my science hat on, looking at the literature, it sort of suggests you need to have at least 3 hours of recovery after a high intensity running session if you're going to do strength training on the same day, and ideally at least 24 hours recovery after a strength training session before you do the running session. And so those kind of recommendations have emerged from partly the literature that I've been referring to, so strength training added to a distance runners program, but also the kind of wider concurrent literature.
To tune into the full episode 148, featuring Rich Blagrove, author of Strength and Conditioning for Endurance Runners, jump over to wherever you get your podcast from and enjoy the whole episode. While there, don't forget to peruse the archives dating right back to episode 1, featuring surf lifesaving Ironman champion Ali Day. For now, let's jump back with Mick Hughes, physiotherapist and exercise physiologist, on all things ACL injury rehabilitation on this expert edition. Mick, you, in your experience so far, have seen times where I'm sure everything seems like it's ready to go. People have been diligent in their application with the rehabilitation, well led by a well-informed physiotherapist, but things can still go wrong on return to sport. True?
Yes, yeah, absolutely. And I was certainly a perfect example of myself actually being in that position too. Our netballer who was going through rehab when I was with the netball team, she got back to sport at 11 months and then nine rounds in injured her other side. So we were very thorough with everything. We looked at everything. Her movement quality was really good, but some people are just unlucky. But some people, it can be quite obvious that they're not quite ready to go back to sport despite them passing some of those objective numbers. And I've had a couple of cases recently where a person has come to see me for a second opinion. Their surgeon's been giving them the all clear, but they're still not 100% sure whether or not they're ready to go back to sport. And when you look at them run, jump and land, especially landing, their movement quality is still pretty poor on both their affected side and their unaffected side. So sometimes these objective numbers, particularly the hop tests, can really hide the movement qualities that actually led to the injury occurring in the first place. And unless you address those movement qualities, so what we're talking about here is that knee collapse inwards, you see those on the hop tests, you want to make sure that person then goes away and does a bit more training before you give them the all clear to go back to sport. I've had a few cases recently where people have passed tests and I've said, look, numbers-wise, you're great, but your movement quality sucks and you need to tidy that up before we give you the green light.
Yeah, okay. So people make it back and they need to work with someone, that's really important here, that knows what they're doing, and if not, find someone that does. So Mick, let's say the return to sport's successful, they're back engaged in what they love to do, and it doesn't or shouldn't stop there, correct? You've termed phase 5 prevention of re-injury. Surely though, Mick, after I've dedicated myself to 9, maybe 12 months of rehabilitation, incurred the costs of working with someone that knows what they're doing, put the time and energy in, can't I just stop?
No. And the reason being is that we actually know that, and particularly those young patients, especially those under the age of 20 and certainly 25, if we're sort of taking that little step further forward, the highest risk time point of having another ACL injury is in the first 1 to 2 years upon your return to sport. So you might get back and play 1 or 2 games. You go through the rehab, you do everything by the book, you pass all the tests, and you're flying. Yet you go back to sport, you might get a few games in and be killing it, but then, the next game you go and tear your ACL or the other side. Now, we know that first 1 to 2 years is really that critical time point of you going to do another one. So that's why we've got that ongoing injury prevention program recommendation in the mix, so that when you do go back to sport, we don't just rest on our laurels and we don't sort of make you comfortable that everything's going to be okay. We need to be really taking a lifelong commitment to your ACL and making sure that you stick to this knee plan for at least the next 1 to 2 years to even give you a bit more of a safety net. Now, these injury prevention programs, depending on your sport, are pretty widely available. Those that play soccer, those that play netball, those that play basketball, those things, they've got greatly recognised and easily accessible programs. The FIFA 11 Plus, the netball knee, the PEP for basketball and other court-based sports, they're widely available and easily found on the internet. So there's no excuse that those programs aren't continued on forever while they're playing sport anyway.
And you outlined that ideally it's performed more than once per week. So what, up to 3 times? Or
I tell everyone that once you go back to sport, these injury prevention programs should be done before every training session that you complete and every game. So the best value in these programs are done in high doses. So you need at least 10 minutes, ideally 15 minutes to do this program, up to 3 times a week. So if you're training twice and playing once, it should be done before every training session and game. And that'll give you 45 minutes of injury prevention per week, which we know adds a lot of safety around your knee to reduce the risk of future ACL injuries.
Mick, thank you for taking us through those 5 phases and the pre-op phase there and the importance of each. That's terrific. Mick, in terms of bringing our time together to a bit of a close, there was a prior featured guest who was an expert addition, Dr. Christopher Chulo, who's a knee orthopaedic surgeon here on the Gold Coast, where we're recording this from. And he has a special interest in ACL rehabilitation and in preventing ACL injuries in youth. And he had noted that there had been a rising tide and trend in the frequency or the incidence of ACL injuries in the youth. And when I asked Chris around what he believed to be the driver of that, his opinion was that the kids these days tend to be a lot bigger and stronger, doing a lot of gym work, and as part of that they can lose some of their reaction time to respond to moments with their knees when they're running and training. So have you observed that, and what would you deduce to be the driver of that?
Yeah, I think Chris got a very valid point there, and I'd say that would certainly be part of the process. And I sort of commented this about on social media recently. That I think we live in an age, especially with younger athletes, to be fitter, faster, stronger, and jump higher, and that. But who's teaching these kids how to brake? Who's teaching these kids how to land properly and decelerate and absorb forces? And I think that often gets overlooked in this quest to be faster, to be stronger, and to be more agile. That often kids aren't taught how to decelerate and to land properly, and that's when the ACL is going to tear, when you're decelerating and going to change direction, or when you're landing from a jump. So I think you can have these really strong, fast kids, but that strength is only as good as the brakes that are applied when you're trying to slow down. And we know that really key part of ACL injury prevention is actually teaching people how to decelerate and to land properly. Other people have sort of commented about this kind of stuff is that sometimes these kids that we've got out there, they often, we've probably got a bit more of a technologically based, group of kids getting around these days, where they probably a bit more sedentary than usual, but then going out and doing all this high intensity exercise that may be a bit unaccustomed. So, there's an argument there that maybe these sort of, sedentary kids that are tearing their ACLs, even though they're active, they may be put at risk because their movement patterns aren't trained as frequently as maybe years gone by. I don't know how strong that argument is, but I thought it was a bit of a valid reason there. But look, I don't know why there's a sudden spike. Like Chris's paper, I love the paper, love the research he's performed there, and it's very eye-opening. Certainly in the last 10, 15 years, there's been a jump in that 14 to 25 age group. like I said, I think my theory has probably got something a bit more down to it, is that inability to land properly and to shock absorb better.
Yeah, no, thanks for sharing your insights there, Mick. Mick, finally, if you could boil everything you've learnt as a physiotherapist over your career to date down to one piece of advice regarding overcoming an ACL injury, what would it be?
This is good. It's a great question, and I'm a really strong advocate for open kinetic chain exercises during ACL rehab. And now, when I was going through university and through my first couple of years, I was scared as hell of prescribing knee extensions for my ACL reconstructed patients, because the way we were taught at uni and the surgeons at the time that I was working with, they said, you do knee extensions, you'll stretch the graft. Now, going through the research recently and being a bit more sort of open-minded and sort of, delving into the research side of things a little bit more, it's actually, we're starting to see that open kinetic chain exercises like knee extensions can be added in safely without risking stretching the graft and impacting on function and ACL laxity and all these kind of things at a later date. Now, the beauty of adding in these knee extensions is that we can really isolate that quad that has been impaired due to the injury and due to the surgery. And we know this quad, if left unattended, can continue to fly under the radar in terms of strength and subsequently deload the knee and unload the knee, making it more susceptible to pain and to changes through the knee at a later date. So we need that quad to be really highly functioning to be able to shock absorb and to land better, to decelerate. But as I said to you before, a lot of people will squat with just a body weight and unload that affected knee. Now, unless you isolate that quad, you can fly through rehab consistently underloading that quad and certainly not get the outcome that we'd like you to see. And we know that for every 1% in limb symmetry under 90%, so when we look at your quad symmetry left and right, for every 1% under 90%, your increase of re-injury is up by 3%. So to put this into perspective, if you have got 80% quad symmetry, your risk of a future ACL injury is 30% higher than those that have got 90% or more. So simply having higher quality quad strength will protect you, and it'll help you run better, shock absorb better, land better, and decelerate better. Now, a lot of people that I see in the clinic, they don't do knee extensions because their surgeon told them not to, because they're going to stretch the graft. Now, knee extensions can be added in safely after 3 months through full range. All right, there's been no evidence to say that it stretches the graft at a later date, certainly not when compared to other studies. The problem is often if it's added in early through full ranges, that's when it can stretch the graft, okay? So anyone out there, don't just go adding them in there willy-nilly. Certainly work with your physiotherapist, but we know that after 3 months it's a safer time point to add in those knee extensions. So that's one big thing I've learned over the time of researching ACLs, is that knee extensions can and should be done to improve people's outcomes.
Yeah, and get the quads strong. You just can't overlook it.
Quads are king.
Quads are king. Brilliant. What a way to finish this expert edition on ACL rehabilitation. Mick, fun question just to finish off. 3 people at a dinner table, Mick Hughes, living or past. Who's at your table and why? Excluding family.
Gosh. Yeah, this is a ripper. Ricky Gervais, because I just think he's just a shit stirrer. Sorry for my French, but he's just he's a funny man and a bit of a pot stirrer, and I just like the way his brain works. And he was a favourite comic of mine growing up through the 2000s. I watched The Office a lot, and I think he'd just be a ripping bloke to sit down and talk to. LeBron James, I'm a very big basketball fan, and he's just an athlete. Like, to play almost every game of his career and be at the top of his game and just dominate the sport. I just would love to see how his brain ticks and what motivates him and just how he sort of gets up time and time again to play his chosen sport.
Mick Hughes, thank you very much for your time and sharing your insights and years of clinical wisdom around this topic, and also just general rehabilitation for us today.
Thanks, Brad. Thanks for having the time for me and taking some time out of your busy day to get me on and have a chat about ACLs, mate. I've enjoyed it. And I've hope all your listeners learned something from my experiences working with ACL reconstructed patients.
And Mick, if people want to find out more, purchase the Melbourne ACL Rehabilitation Guide 2.0 to take to their physiotherapist, or perhaps they're a therapist themselves listening in. Where can they find that, and where can people find out and follow you more?
Yeah, so look, you can get the ACL Rehab Guide, Melbourne ACL Rehab Guide. You can get it from the Premax website, so Randall's Premax website. Alternatively, you can just Google search Melbourne ACL Rehab Guide 2.0. You can follow me. I'm very active on Twitter. My handle's at Mick W. Hughes. Also active on Facebook and Instagram under the usernames mickhughes.physio. Those of you on LinkedIn, pretty busy on there too. So just search for Mick Hughes Physio there as well. So cover all four bases.
Easy to find. Mick Hughes, thanks again.
Thanks, Brad. Appreciate it, mate.
So there you have it, another episode of the Physical Performance Show, and I hope you took some pearls away from this expert edition featuring Mick Hughes. If you did, then please let Mick know. You'll find Mick over on Twitter at Mick W. Hughes, and also over on Instagram at mickhughes.physio. If you have any feedback for myself around the Physical Performance Show, you'll find me over on Instagram and Twitter at Brad_beer. Big thanks for the podsies, guys. That is a screenshot of the episode that you're enjoying and a tag of the show's Instagram handle at Physical Performance Show. And they are always a real treat to see coming through over on Instagram. So if you're enjoying an episode this week, be sure to take a screenshot and share it to social media at Physical Performance Show. Big thanks to those leaving reviews over on iTunes. That certainly helps the show grow, but it also serves as fuel to keep these shows coming each and every week. Big thanks this week to show reviewer Justin McDonald. Justin rated the show 5 stars and commented, "If you are interested in health, your body and or fitness at any level, then I urge you subscribe to this podcast and start listening. Like me, I'm sure you'll find yourself scrolling through the archives, listening to past shows. From athletes Lisa Waitman, Jess Trengove and Liam Adams, coaches Adam Diddick and Dick Telford, authors and medical professionals, Dr. Jacob Harden, Alex Hutchinson and Dr. Peter Bruckner, plus many more I'm eager to discover. Last of all, thank you again, Brad. Your insights and knowledge are worth listening to. Your podcast would work very well as a weekly TV show, food for thought. Keep up the great work because I sure love listening and learning." Justin, thank you for the review. That's absolutely fantastic. And be sure to reach out and we'll get a copy of my running and jogging bestseller, You Can Run Pain-Free, the second edition, out to you in the post. Big thanks also to those who have been subscribing to the show. Yes, that keeps the show coming to you each and every week as the episodes go live on Thursday evenings, but it also is the single greatest way to help the show get into the earbuds of more people just like yourself looking to pursue and perform at their physical best. So thank you for hitting subscribe this week to the Physical Performance Show if you're yet to do so. Another huge thanks to this week's show supporter, the Gold Coast Marathon. If you are looking for a great mid-year event or challenge, then don't miss the Gold Coast Marathon. It's one of my favourites every year, with events ranging from the full marathon through to the junior dash. Jump over to goldcoastmarathon.com.au and register today. Big thanks as always to the 3 very good folk who work behind the scenes to bring the show to you each week. Daryl Misson, our audio engineer, Susan Wilkin, our show administrator, and Matthew Walding on all things graphic design. Coming up next week on the Physical Performance Show, I bring you an interest edition featuring Commando Steve Willis. That's right, Commando Steve of Biggest Loser and Australian Survivor fame. You're going to really enjoy Steve's keen insights into all things physical performance, so be sure to be tuning in next week to episode 149 of the Physical Performance Show. Until then, keep pursuing your physical best performance. I'm Brad Beer, and this has been the Physical Performance Show.